Imagine for a second that you have a tiny, like a really painful paper cut on your hand. It's stinging, it's raw. Now imagine that instead of putting a bandage on it, you accidentally spill a few drops of lemon juice on that cut.
Oh, that sounds awful.
Right. But imagine doing that every single day, multiple times a day.
I mean, it sounds agonizing. You're never giving the tissue a chance to actually heal. You're just constantly re-injuring the site day in and day out.
Exactly. So now imagine that paper cut is actually a chronic autoimmune condition. And it's on the most sensitive, delicate skin on the entire human body.
Yeah.
Today, we're doing a deep dive into lichen sclerosus, and we're trying to answer one highly practical, surprisingly controversial question.
It is surprisingly controversial, yeah.
It really is. The question is, can something as simple as trapped moisture or like minor urinary incontinence actively make this disease worse?
Right.
And for you listening, whether you're a clinician navigating this with patients or maybe someone living with the condition yourself, we're just, insanely curious about how our environment and biology collide. Understanding this specific mechanism is just entirely transformative.
It really is. And the short answer to that question is a resounding yes. I mean, chronic moisture in urine absolutely worsen the condition.
Wow. Absolutely worsen it.
Absolutely. But, the real value here is understanding the why. Because when we look closely at the biology of what is actually happening on a microscopic level, like between the skin, the immune system, and our physical environment, it completely unlocks the key to managing this disease.
It gives you some control back.
Exactly. It takes it from feeling like this mysterious, uncontrollable curse to something with very clear mechanical levers that we can actually pull.
So, okay, let's unpack this. Because before we introduce things like moisture or urine, we kind of need to understand the environment they're entering.
Right, the baseline.
Yeah, the baseline. So lichen sclerosus is notoriously uncomfortable. It's primarily driven by intense, unrelenting itching.
And we're looking at skin that becomes very pale, almost white in color.
Right, and it gets incredibly thin, taking on this like fragile tissue paper quality that is highly prone to tearing.
Yes, and in severe cases, it leads to significant structural changes.
Yeah.
And scarring.
Which is awful.
It is. Those structural changes are deeply distressing for patients. We see things like the burying of the clitoris or the labia minora essentially shrinking and just fusing together over time.
Wow.
Yeah, it completely alters the anatomy. And the underlying driver of all this tissue destruction is this overactive, localized inflammatory response.
Wait, I need to stop you there.
Yeah.
Because we just established this is an inflammatory autoimmune-linked disease, right?
Correct.
Meaning it's an internal genetic issue.
Yeah.
I know it's often clustered with other autoimmune disorders like thyroid disease or vitiligo.
It is, yeah.
So how can external physical trauma, things like riding a bicycle or wearing tight clothing or even friction from wiping, possibly cause an internal immune system flare-up?
It sounds contradictory.
It doesn't make logical sense. Why does external friction cause an internal disease to worsen?
So that paradox is explained by a physiological mechanism. In dermatology, we call it the Koebner response.
The Koebner response.
Yeah. And the Koebner phenomenon basically occurs when skin lesions actively appear, or get worse, right along lines of physical trauma.
Interesting.
So think of a patient with lichen sclerosus as having an immune system that is already hypersensitized in that specific area of the body. The immune cells are essentially, standing at the gates, armed to the teeth, completely on edge.
They're just waiting for any excuse to react.
Exactly. So when you introduce friction or any kind of external damage to those epidermal cells, it acts like a microscopic flare gun.
A flare gun.
Right. The damaged rubbed skin cells send out these distress signals, and that overactive immune response rushes right to that specific site.
Oh, I see.
The body actually thinks it's repairing the friction damage, but because the immune system is miscalibrated, it massively overreacts.
So it sends too much help.
Way too much. It floods the area with inflammatory cytokines, and that ultimately causes the scarring and the white plaques that are characteristic of the disease.
So the skin is basically the victim of friendly fire.
That is a perfect way to put it.
I mean, the body thinks it's helping heal a tiny friction wound, but the resulting immune storm destroys the healthy tissue right in the crossfire.
Which means managing this disease really requires us to be hypervigilant about identifying what is pulling the trigger on that flare gun.
Right. And when we think of trauma or friction pulling that trigger, our minds immediately go to mechanical things.
The obvious stuff.
Yeah, the bicycle seat, the tight jeans, the rough toilet paper. But here's where it gets really interesting.
Yeah.
The most insidious chronic trigger isn't something we wear or do, it's urine. The clinical data points heavily to something called the urine occlusion hypothesis.
And this hypothesis completely shifts how we view the daily management of the condition.
Occlusion just means blocking, right?
Yeah, occlusion just refers to blocking or sealing something in. So the hypothesis suggests that microscopic droplets of urine get trapped or sealed right against the skin of the external genitalia.
Okay.
And that trapped, localized environment actively drives the disease process forward.
Now, I get that urine is wet and, being constantly damp just isn't great for the skin. But why does that actually cause a physical structural breakdown of the tissue?
It's a good question.
Because taking a long bath doesn't cause scarring. What is the skin actually reacting to?
It all comes down to the chemical interaction. You see, normally our skin relies on being slightly acidic to maintain its barrier.
Right, the acid mantle.
Exactly. We have an acid mantle that protects the underlying cells. But when urine sits trapped on the skin, local bacteria immediately start to digest the urea that's present in that urine.
Okay.
And as they break it down, they produce ammonia as a byproduct.
Oh, and ammonia is highly alkaline.
Highly alkaline, so it completely neutralizes and strips away that protective acid mantle. But it gets worse because the high alkaline pH also activates specific enzymes that reside on the skin called proteases and lipases.
Wait, okay. Proteases break down proteins.
Yeah.
Lipases break down fats.
Mm.
And our skin barrier is primarily composed of proteins and fat.
Exactly. The ammonia is literally turning the skin's own enzymes against itself.
Oh, wow.
It is like a slow-motion, microscopic chemical burn. The structural proteins and lipids holding the skin cells together are being actively digested.
That is terrifying.
So you have a physical barrier that is already under severe attack from the inside by the patient's own immune system, now being chemically eroded from the outside.
It's a devastating dual assault.
It really is.
And the clinical data backing this up is staggering. Like, we looked at this cross-sectional study looking at the prevalence of urinary incontinence in adult females.
Wow.
In the control group of women who did not have the condition, the rate of incontinence was 34%. But in the women who did have vulvar lichen sclerosus, it jumped to 63%.
63% is a massive statistically significant correlation.
Almost double.
Yeah. If a patient is presenting with vulvar lesions, they are almost twice as likely to be experiencing urinary leaks compared to the baseline population.
But the most undeniable proof of this urine theory actually comes from looking at men, right?
It does.
Because if you look at male patients, the condition almost never occurs in those who are circumcised early in life.
Almost never. Furthermore, for adult men who develop lesions on their foreskin later, a surgical circumcision is often completely curative.
Completely curative.
Yes, the disease process just stops dead in its tracks.
Because you remove the physical pocket, the foreskin that was trapping those microscopic drops of urine against the skin.
Precisely.
If you remove the trapped urine, the disease goes away. That is the massive smoking gun for the urine occlusion hypothesis.
It is a massive smoking gun.
And even in women, the classic presentation of the lesions is often described as a figure of 8 shape.
Right. It circles the vulva and extends down around the perianal area.
Exactly. And this perfectly geographically maps to the exact areas exposed to urine as it tracks backward when a woman sits on a toilet.
It's really brilliant medical detective work, honestly. The physical distribution of the disease perfectly matches the exposure path of the chemical irritant.
It's incredible.
And when you combine the chemical burn of the ammonia with the sheer physical moisture constantly degrading the stratum corneum, which is the outermost layer of the skin, the tissue just becomes macerated. It gets waterlogged and incredibly fragile.
Which brings us to a really dark irony in all of this.
Yeah.
Because, what is the logical, totally rational human response if you are experiencing urinary leaks?
You try to manage it.
You go to the store and you buy incontinence pads or panty liners.
Right.
But based on everything we've just discussed, that mechanical solution is a brutal catch-22.
It creates an incredibly hostile environment for healing. Let's just look at the microclimate an incontinence pad creates.
Okay.
By design, it has to be impermeable to protect outer clothing, right?
Right.
That impermeability means it traps all the ambient body heat, it traps all the moisture, and crucially, it presses right up against the tissue, creating constant, all-day physical friction with every single step a person takes.
Boom. The Kobner response.
Yeah.
We are right back to friction, acting as a flare gun for the immune system. But now it's happening in a hot, wet, highly alkaline environment.
Exactly. And it triggers what we call a treatment paradox in dermatology.
A treatment paradox.
Yeah, because the absolute gold standard medical treatment for this condition is the consistent application of an ultra-potent topical steroid, like clobetasol propionate 0.05%.
Right, strong stuff.
The goal of that ointment is to suppress the localized overactive immune response and just halt the inflammation.
But, and here's the paradox, if a patient is leaking urine, they are likely going to the bathroom and wiping the area with toilet paper much more frequently throughout the day.
Yes.
So they apply this very specific, crucial medication in the morning. 2 hours later, they have a small leak, they go to the bathroom, wipe, and the medicine is completely gone before it could even absorb.
And even if they aren't wiping it away, the incontinence pad itself acts like a highly absorbent sponge.
Oh, man.
It presses directly against the skin and literally soaks up the steroid ointment.
So it's not even getting to the skin.
Right. The patient believes they are fully complying with the treatment. They are doing everything their doctor instructed, dealing with the daily hassle of the regimen, but the medicine simply isn't making it into the cellular tissue.
The psychological toll of that has to be exhausting.
It's incredibly frustrating for patients.
Because the very products you rely on to maintain your daily dignity, and manage the incontinence, are actively neutralizing the only medical treatment that can save your skin.
Yes.
And if the treatment is neutralized, the inflammation just progresses, which leads us to the anatomical feedback loop.
And this is where the structural changes shift from being uncomfortable to profoundly problematic for basic bodily functions.
Right.
If the inflammation goes untreated or undertreated because the medication is being wiped away, the chronic immune response causes the tissues to scar and fuse.
The labial fusion we mentioned earlier?
Exactly. As the inner lips of the vulva fuse over the urethra, it acts exactly like a physical barrier placed over the end of a hose.
Oh, so it disrupts the normal, clean, directional stream of urine.
Yes. Instead of a clean flow directed away from the body, the urine hits that scarred, fused tissue and it sprays, or it slowly dribbles.
Which means an even larger volume of urine is dispersed across a much wider surface area of the skin.
Exactly. And worse, it gets trapped in all the new anatomical nooks, crannies, and pockets created by the scarring.
Which means more trapped urine, more bacterial breakdown into ammonia, more chemical burns, more Koebner response, which causes even more scarring, which causes more fusion, which causes worse spraying.
It is a terrifying, vicious cycle.
I mean, for you listening, who is sitting here thinking, this sounds incredibly bleak, how on earth do we break this cascade?
So if we connect this to the bigger picture, it is entirely manageable, but it requires attacking the cycle at multiple intervention points simultaneously.
Okay, where do we start?
The first step isn't even a prescription medication. It's changing the fundamental daily care of the skin to protect whatever barrier function is left.
Right.
The universal recommendation is to completely ditch traditional soups or foaming shower gels in that area.
Because traditional soap strips away the natural lipids, which we just established, are already being eaten alive by the ammonia lipases.
Precisely. Instead, you switch to an emollient soap substitute. It cleanses the area, but actually leaves a protective layer of moisture behind.
Okay, that makes sense.
And after washing or after using the toilet, the advice is to dry the area meticulously by gently patting with soft tissue, never rubbing.
Right, you want to avoid any friction trauma that could trigger the Koebner response.
Exactly. And at night, ditching underwear completely allows the skin to breathe and recover from the occlusive, humid environment of the day.
But what about the urine itself? I mean, if someone is actively dealing with stress incontinence, say they sneeze or laugh, and a little bit leaks, how do they protect the skin from that active ammonia burn throughout the day?
Barrier protection becomes the most critical tool in the daily arsenal. The protocol highly recommends the frequent use of a thick, greasy emollient.
Like what?
Like yellow soft paraffin, most commonly known as Vaseline, or specialized medical barrier creams like Cavalon.
Oh, so you're essentially waterproofing the tissue.
That is the perfect way to visualize it. You are applying a robust physical shield.
I see.
So when a urine droplet escapes, it hits the layer of petroleum jelly, not the epidermal cells. The ammonia stays suspended on the outside of the barrier. Yeah, the proteases and liposis cannot eat through the synthetic barrier cream. It completely stops the enzymatic chemical burn in its tracks.
So the barrier cream neutralizes the environmental trigger from the outside.
Exactly.
But we still have a hypersensitized immune system to deal with on the inside. That brings us back to the medical treatment. The ultrapotent steroids.
The cornerstone of treatment, yes.
Consistent use of clobetasol propionate is the absolute cornerstone here. But we really have to address the elephant in the room.
Skin thinning.
Yes, because if you spend 5 minutes on the internet researching topical steroids, you will be bombarded with terrifying warnings about how they cause skin thinning. And given that this disease already makes the skin paper thin and fragile, patients are naturally, understandably terrified to use these potent creams.
It is the most common and without a doubt the most damaging misconceptions surrounding this disease.
Tell us why.
The warning labels on steroid creams are generalized for typical everyday skin conditions like mild eczema or contact dermatitis.
Right.
Applying ultra-potent steroids to healthy skin over long periods will cause atrophy. But lichen sclerosus is an entirely different beast.
Okay.
The active, untreated inflammation of the disease itself will cause infinitely more structural damage, permanent scarring, and dangerous skin thinning than the steroid cream ever will.
The disease is the monster destroying the tissue, not the medicine.
Exactly. The medical consensus is absolute on this. When used correctly under clinical guidance, which usually involves a tapering regimen where you use it frequently to halt a flare, and then step down to a sparse maintenance dose of maybe once or twice a week, it is incredibly safe and effective.
Okay, so you taper it down.
Right. The steroid halts the destructive immune storm, and once that inflammation stops, the skin is actually allowed to recover its normal thickness, elasticity, and texture.
Wow.
Refusing the steroid out of a misplaced fear of skin thinning is guaranteeing that the unchecked disease will thin and scar the skin permanently.
That distinction changes everything. You aren't thinning the skin, you are giving it the peace and quiet it needs to rebuild.
Yes.
But to bring this all full circle back to our core question,
Yeah.
a patient can use all the barrier cream and all the correctly prescribed steroid ointment in the world, but if they have a leaky pipe, they are fighting a losing battle, aren't they?
They really are.
The clinical protocols emphasize that treating the underlying incontinence is just as vital as treating the skin.
It is the missing puzzle piece that finally brings lasting relief for so many patients. Managing this condition isn't solely a dermatology issue. It demands a holistic urogynecological approach.
Because most forms of urinary incontinence are actually highly treatable.
Very treatable.
It's not just a reality of ages or something you simply have to endure because you had children or went through menopause.
Not at all. Referring the patient to a specialized pelvic floor physiotherapist can work wonders, particularly for stress incontinence.
Oh, for sure.
It involves retraining the musculature to properly support the urethra and bladder. And there are also targeted medications for overactive bladder and even minor, highly effective surgical procedures if conservative measures fail. If you cure or drastically reduce the incontinence, you eliminate the constant chemical irritation. You eliminate the need for the friction-causing moisture-trapping pads.
Yes.
And you finally give the steroid cream the pristine, undisturbed environment it needs to actually absorb and heal the skin.
It is a perfectly linked chain of events. And we really need to underline why breaking this cycle and getting the inflammation under control is so critical.
Yeah, we have to touch on the risks.
Right, because aside from the sheer impact on daily quality of life, the chronic pain, and the severe disruption to sexual function, there is a significant long-term health risk here.
We must be forthright about the data. Women with this condition have approximately a 3 to 5% lifetime risk of developing a specific type of skin cancer called squamous cell carcinoma on the vulva.
And 3 to 5% might sound like a small number in isolation, but compared to the baseline risk in the general population, that is highly significant.
Very significant. And the current medical consensus strongly indicates that this cancer risk is directly tied to the chronicity of the uncontrolled inflammation.
Because of the cellular turnover.
Exactly. Think about what is happening on a cellular level. The immune system is constantly damaging the tissue, and the body is constantly trying to repair and replicate those cells.
Right.
Over decades, that rapid, chaotic cellular turnover drastically increases the statistical probability of a genetic mutation occurring. And that mutation is what leads to cancer.
But there is a massive silver lining in the data regarding that risk.
There is. The data clearly shows that patients who strictly adhere to their maintenance steroid therapy, who use their barrier creams, and who keep their inflammation completely suppressed, essentially reduce their cancer risk right back down to the baseline of the general population.
Getting the microscopic environment under control truly is preventative medicine in the highest, most literal sense.
It is about taking the flare gun away from the immune system, neutralizing the chemical burns, and keeping the cellular environment perfectly peaceful.
So just synthesizing everything we've pulled from this deep dive. Yes, chronic moisture and urinary incontinence absolutely, undeniably worsen vulvar lichen sclerosus.
Yeah. No question about it.
It isn't just a matter of discomfort or bad luck. It is a perfect destructive biological storm. You have the chemical irritation from the ammonia in the urine literally digesting the structural proteins of the skin.
Yeah.
You have the mechanical friction and trapped heat from incontinence pads triggering the Kobner response and wiping away crucial medication.
Right.
And you have an underlying immune system that is completely compromised and overreacting to every single piece of that puzzle.
And this is the main takeaway. The cycle is entirely breakable.
It is breakable. By addressing the pelvic floor and the incontinence itself, by using thick barrier creams to literally waterproof the skin against enzymes, and by fearlessly applying the correct prescribed steroid regimens to halt the immune response, patients can reclaim their skin, their anatomy, and their comfort.
It requires daily vigilance and a deep understanding of the mechanics at play, but the physiological results are transformative.
It really makes you pause and look at human health with a completely different lens.
For sure.
And we want to leave you with this final provocative thought to mull over today. We spend billions of dollars and countless hours looking for incredibly complex genetic or systemic autoimmune answers to chronic diseases. But this deep dive makes you wonder how many other chronic, mysterious, painful, inflammatory conditions in our bodies are actually being triggered or simply kept awake by simple, everyday environmental exposures that we completely take for granted.
It's a fascinating question.
Because sometimes the biggest threat to the fortress isn't an army attacking from the outside. It's the invisible asset we don't even realize we're leaving at the gates.